Good evening, everyone, and welcome to webinar 1 of our two-part endo-hepatology webinar series. Tonight, we will be discussing advances in EUS-Guided Liver Biopsy with our guest speaker, Dr. Harshit Khara from Geisinger Medical Center. We have a few topics to get through this evening. My name is Rachel Kostanek. I'm the product manager for our EUS scopes and needles here at Olympus. This presentation is for your general knowledge and background only. EUS is to be performed according to standard technique and is left to the operator's experience and skills. Olympus makes no representations, warranties, or other expressed or implied warranties or guarantees regarding the accuracy, reliability, or completeness of this information. Proper attribution should be provided for use of the information contained in this presentation. Under no circumstances shall Olympus or its employees, consultants, agents, representatives be liable for costs, whether direct, indirect, special, incidental, consequential, or otherwise, that may arise or be incurred in connection with the information provided or any use thereof. Dr. Harshit Khara is the authoring physician of this presentation, is a paid consultant of Olympus Corporation of the Americas. All images and videos, unless otherwise cited, were provided by Dr. Harshit Khara. The conclusions made by Dr. Harshit Khara were his own conclusions, and remarks are completely independent of Olympus. Additionally, Dr. Marvin Yu is a paid consultant of Olympus Corporation of the Americas. The comparison to the competition has been written to the best of our knowledge at the date of publication. Please keep in mind that our competitors enhance their products as well, so their products may have changed. Make sure you use competitive comparisons carefully in your conversations. This material does not constitute medical or legal advice, should not be relied upon as such. This material should not be considered a substitute for carefully reading all applicable labeling, including instructions for use, IFU supplied with the devices, and published peer-reviewed articles concerning the topics presented. Therefore, using or selling any product, please thoroughly review the relevant user manuals, instructions, warnings, and cautions. The techniques, instruments, and settings can vary from facility to facility, and it's at the clinician's decision and responsibility to decide in each clinical situation which mode and settings they use. Like I mentioned, this is part 1 of our two-part endo-hepatology webinar series, so please be sure to register and join us for part 2 on Wednesday, February 23rd, same time as this evening. Dr. Marvin Yu will be talking a lot about understanding the role of EUS in advanced imaging in the diagnosis and management of liver disease, specifically gaining insight into optimal techniques for advanced EUS imaging and shear wave measurement. Moving into the Olympus Complete EUS solution, Olympus delivers today's most comprehensive EUS solution with a robust portfolio of EUS processors, endoscopes, and devices. And please use the resources section on your screen to learn more about the Olympus Complete solution. Additionally, on your screen, you will find a box for question submission. So please submit your questions for Dr. Khara throughout the duration of his presentation. We will be able to answer those in the Q&A portion of the presentation. Now, to officially welcome our guest speaker, we are very excited to welcome Dr. Harshit Khara from Geisinger Medical Center. Dr. Khara earned his medical degree from Seth GS Medical College and KEM Hospital in India. He moved to the U.S. to complete his residency at Drexel University College of Medicine. He completed 3 fellowships and 1 transplant hepatology at the University of Nebraska Medical Center, 2 in gastroenterology at Yale University School of Medicine, and 3 in advanced therapeutic endoscopy at Geisinger Medical Center. He's currently the Director of Endoscopy, Endoscopic and Translational Research in the National Pancreas Foundation at Geisinger Medical Center, and he is also a Clinical Associate Professor of Medicine at Geisinger. Dr. Khara has been invited as a lecturer for numerous programs and has published and co-published extensive clinical research in the endo-hepatology field. We are pleased to welcome Dr. Khara this evening. Thank you so much for being with us.
Thank you, Rachel, for that introduction, and Olympus for providing this platform to be able to share our data here at Geisinger, and a topic that's very near and dear to our hearts here at the endo-hepatology team at Geisinger Medical Center. And I'd be happy to walk us through this evening on our experiences, protocols, and algorithms for EUS-Guided Liver Biopsy. So again, good evening, everybody, and let's jump on in. So on the agenda, we'll go over the background of EUS-Guided Liver Biopsy. I'm proud to be part of a team here at Geisinger who have been pioneer in not just spreading this technique, but also perfecting it, and working with our interventional radiology and hepatology colleagues on taking this to the next level. We'll review the whys of the EUS liver biopsy, the patient selection, the procedure details on how we perform this, and also the clinical literature that we have been proud of being a part of here at Geisinger. So this is the patient pathway that we've developed here at Geisinger, where people who have increased liver enzymes, normally get referred by the primary care by other physicians to our hepatology colleagues within our GI hepatology division here at Geisinger. And if they are suspected to have liver disease based on their biochemical workup or their serological workup, usually they need some form of liver histology assessment. Now, they would go for an imaging modality to rule out a biliary cause, to make sure there is not a biliary pathology, in which case they may require an ERCP. But if there is no biliary obstruction in the same session, we're able to offer these patients an EUS liver biopsy. So if you have elevated liver enzymes, instead of going for an ultrasound separately and a IR-guided biopsy separately, or an endoscopic ultrasound separately, we're able to basically merge this into one common technique. So the patient would come in, we would do an endoscopic ultrasound, they have a biliary pathology, we could proceed with the RCP. They don't have a biliary pathology such as a ductal obstruction, and we feel that this is a parenchymal process, then we were able to offer a liver biopsy. And therein comes the question, where do you send the patient? Do you do an EUS-guided liver biopsy? Do you do a transjugular liver biopsy? Or are you able to do a percutaneous liver biopsy? And the whys of the USLB is if you need an endoscopy for abdominal pain, for variceal screening, those patients are already coming for endoscopy. Or if you need a biliary, gallbladder, pancreas evaluation, or a suspected FNA, again, patient is already undergoing sedation and endoscopy, and we can kind of partner with an EUS-LB along with that. Is there a need for sedation or pediatric patients? We have extensive experience with also. Those are all people who are very good candidates for an EUS-LB. Now, transjugular liver biopsy, historically, and when I say historically, up until the recent past, if they need a portal pressure measurement, those patients would require to go to IR. But again, now with the advent of portal pressure also being a part of our endo-hepatology portfolio, we're able to do EUS-guided PPG or portal pressure measurements in conjunction with their EUS liver biopsy. So in the past, we would say, if there's a portal pressure need, those patients would go to IR. But now even those patients are part of our EUS-LB portfolio. So again, conventional biopsy techniques of percutaneous and transjugular continue to be the options for our patients. However, we are able to offer another piece of an option, which is the EUS-LB. And the why behind the EUS-LB, first of all, it's safe. It avoids vessel using live Doppler. The data behind it I'll go over, but it has comparable outcome and complication rates as a percutaneous or transjugular access. If patient needs a concurrent EGD or EUS, we're able to offer an equal or superior specimen compared to perc or transjugular methods. And again, we have the option of offering a bilobar sampling. So we do left and right lobe via EUS-LB, and that reduces the sampling error behind these modalities. It's, of course, an improved patient experience. They don't have to wake up and lay on their side for an extended period of time. The recovery is just the same as an endoscopic procedure. So it's convenient, it's cost-effective, as I just mentioned, because it could be a single procedure encompassing their endoscopic ultrasound or endoscopy with a liver biopsy. It's smooth and direct communication within our own division. So we can communicate with our hepatology colleagues. The scheduling is easy because it's all part of one division. And also the action on it based on what the biopsy results show, there is nothing lost in translation. It obviously offers the increased comfort of sedation and analgesia. And also, Geisinger being an integrative health system, we're able to kind of have a cost containment. So instead of sending the patient to 3 different divisions for 3 different procedures where they may require 3 different rides, Here, it's a one-stop shop. They come for an EUS-EGD procedure and get evaluated for ERCP or liver biopsy. And of course, it grows the outpatient referral also, as we can share our data, as we're going to do tonight. More and more referring physicians within the community are now seeing the benefit and the value of sending their patients as a one-stop evaluation. And like I said, it keeps everything within our own division. So the patient selection, as I briefly mentioned, if the patient is already coming in for an endoscopy for any other reason, it could be a Barrett's follow-up, a variceal screening, abdominal pain workup where there is underlying peptic ulcer disease rule out, or if they need a concurrent endoscopic ultrasound evaluation for pancreatic or biliary pathology, or if they require a sedation for liver biopsy, or the need of a bilobar sampling, all of these are very easy cases to tag along an EUS liver biopsy if there is the need for the information for parenchymal liver disease assessment. So again, who are not candidates? So if they have thrombocytopenia, we are going to do this with a 19-gauge F&B needle. So the patients are at higher risk of bleeding. And again, coagulopathy along the same line. So patients with advanced cirrhosis, for example, who have thrombocytopenia and coagulopathy, they still benefit with a transjugular route. Or if there is significant ascites, now this is kind of a gray zone. So if there is a lot of ascites, we never want to go through the ascites fluid. So if there is fluid between the stomach or the luminal and the liver areas, then of course we don't perform an EUS-LB. However, if there is slight ascites or perihepatic ascites that's not between the stomach and the liver, and we are able to find a safe zone, we have been able to easily perform EUS-LB in these patients. And again, the strikeout here, patients have imaging on cirrhosis on imaging, and if they need portal pressure measurements, now we're able to do that with the EUS-guided portal pressure measurement kit in conjunction with the USLB. So that no longer is a requirement for sending them to IR. So the initial setup is a 19-gauge F&B needle. And again, I'll go over the data, but that is kind of our standard protocol now based on our clinical and research experiences. We would remove the stylet and apply wet suction to the 19 F&B needle. So that is flushing the heparin with the Heplock heparin solution and then attaching the suction syringe at full suction filled with 2 cc's of water. So this is the demonstration of a needle prep. So we would use a 19-gauge easy shot F&B needle, and we would prep the needle for the procedure. So in preparation for that, we usually use a Heplock solution. So we would take the suction syringe and the 19 F&B needle, remove the stylet out of the needle, use a heparin Heplock solution, and what it does is it prevents the specimen from clotting within the needle. And we flush the needle with the heparin with just a couple of drops coming out of the needle tip. So this puts the heparin solution inside the needle, and then using 2 cc's of water and applying full 20 cc's of suction to that suction syringe, which is then attached to the back of the needle. So now this gets the needle ready for the wet suction technique. The heparin obviously is left in, it's not flushed through or pushed through, it's left in the needle because when we do the biopsy, that heparin gets sucked up, so it's not injected into the patient. When the suction turns on, it's pulling the tissue into the needle. So the initial approach for the right and the left lobe of the liver, for the right lobe, we would move the linear echo endoscope to the apex of the duodenal bulb. So it's a transbulbar biopsy. We would torque the scope 180 degrees, use the big knob back towards us, using the Doppler, checking the puncture site for any intervening vessels. And we would do 1 puncture with 2 to 3 actuations with a fanning technique, long pass with each actuation. Then we would turn the suction off and take the needle back into the scope and express the tissue out. The same goes for the left lobe, is done through a transgastric access. So we would identify the celiac artery and then go 90 degrees counterclockwise, which is to the left, and then big wheel towards us brings us to the left lobe of the liver. And the same exact technique is used for the left lobe puncture. So ideally, we try to do 1 puncture per lobe with 2 to 3 actuations per puncture. So for the biopsy, I'll demonstrate the technique using a right lobe transduodenal biopsy. So we would pass the echo endoscope to the duodenal bulb. We would identify the liver from the bulb, bring the needle to the tip, puncture into the liver, turn the suction on, do 3 long actuations, turn the suction off, and pull the needle back. Once the needle is taken out of the echo endoscope, we would filter this tissue through this sieve. It's a plastic sieve that we get from our histopathology division. They use this for specimen processing. It's the cassette that we use. And basically what it does is it gets rid of any water or blood. Again, a drop of blood in a cc's of water looks like a lot of blood, but basically when we send these specimen over, they are pure liver cores. So what we do is we take the needle and we move it over this plastic sieve. And then we use the heparin to flush through the needle. So for the specimen prep, we express the tissue by flushing the needle again with heparin over this sieve and then cleaning the specimen with sterile saline. And as you can see, all the water and the blood falls into the silver pan below, and we're able to get pure liver cores right in the formalin cup. So this is sent not as a cytology specimen. These are tissue cores sent as histopathology specimen. And this is an example of a 19 easy shot 3+ EUS-LB specimen. As you can see, there is plenty of cores, more than enough for specimen assessment, both from the left and the right lobes of the liver. So these are cleaned off, and these pure liver cores are then transferred into a formalin container, then goes for histopathology assessment. And our yield has been way more than adequate for what is required in regards to the AASLD guidelines for histopathology cores. So the complete portal triad count is a median of 13 to 17 with specimen length of 32 to 40. So what is the literature behind it? How did all this start? And obviously this all started with our initial multi-center study. The initial question was, is this feasible? Should we be doing it? And can we even get adequate tissue by USLB? So we were one of 8 centers when we had 110 patients with a 19-gauge needle. And between all the aggregate centers, we wanted to make sure this is applicable across different centers across the country. And we found 98 specimen adequacy to obtain a pathological diagnosis with a median tissue length of 38 millimeters and portal count of 14. Our initial study, as you can see from 2015, this was with the 19 FNA needle. And even with that, we had more than adequate specimen. And over time, as I'll share our clinical data, we have evolved that technique to an FNB needle. So this was a feasibility study that showed, yes, we can do USLB. There was no complication rates with this, and we have enough adequate specimen length. And then we worked with our interventional radiology colleagues and compared, well, how does this compare to the other modalities that are established? So again, we looked at EUS-LB specimen adequacy compared to our percutaneous and transjugular specimens. And we found that when we did Biloba US liver biopsy, there was significant more tissue, both total specimen length and complete portal triads compared to percutaneous methods. And it was significantly longer specimen length than transjugular biopsy and similar portal triads compared to transjugular. So definitely when we put this as a comparison to percutaneous and transjugular, we had more than adequate specimens compared to both these modalities. The other question comes up always is, well, what about 19 versus 22? Can we use a 22 gauge needle as there is more comfort? And there is this theoretical safety zone where people feel, well, it's safer to use a 22. And we've shown that there is no difference. We used a 19 and 22 gauge needle, and this was a randomized controlled trial with 80 patients, 40 patients in each arm, randomized to 19 FNA compared to 22 FNB. And we found that the specimen adequacy was significantly higher with the 19 gauge FNA needle, even when compared to a 22 FNB needle. And the main problem lies in the fragmentation. As you could imagine, the 22 cores are significantly thinner as compared to the 19 gauge cores. And the pre and the post processing, there was significantly more fragmentation with the 22 gauge needle as compared to the 19. And in this, you can clearly see, I don't even have to say which is which, but the tiny thinner cores on the left are the 22 gauge needle. And you can see they're much thinner pre-processing. And if you look at the bottom, the post-processing length is, there is multiple small fragments as compared to the 19 cores, which are much thicker, and then post-processing, they retain their length and their pathological assessment. So this was an ex vivo study that compared various different needles that are out there in the market. They looked at six different needles, and they had an explant model in which they had 30 core biopsy specimens. Each needle, each aspirate had 5 actuations, puncturing 4 centimeters into the liver, performed by a single operator. And these were non-overlapping locations. And they compared from left to right the EZ-Shot 3+, the EcoTip ProCore, SharkCore, and the Acquire needles. And the scope position, they tried to introduce the same twists and turns to replicate a normal anatomy. And basically what they found is the 19-1 compared to the 22 when you look at the complete portal trials. So all the 19 gauge needles outperformed the 22 gauge needles. So in that regards, the 19 Acquire, 19 SharkCore, and the 19 EZ-Shot yielded similar complete portal trials. But if you look at the specimen lengths, in this case, the 19 EZ-Shot and the 19 Acquire definitely outperformed the other needle lengths and diameter. So again, this was not an actual human study, but with an explant, this is the closest that has come to comparing all the available needles. So again, it reemphasizes the point of using a 19 gauge F&B core biopsy needle that would give you the best specimen yield. So then it comes down to the technique. Well, do you do 1 actuation, 3 actuations? Do you do 7 to 10 fanning techniques? So we performed a prospective randomized trial comparing the 1 pass, 1 actuation compared to 1 pass, 3 actuation technique. And we had 40 patients that were randomized in both the arms. And biopsies were adequate for pathological interpretations in both cases. So if you do 1 actuation compared to 3 actuations, the adequacy was the same. However, there was significantly higher specimen length and complete portal trials in the 1 puncture, 3 actuation technique. So we feel that doing 3 fanning actuations just with a single puncture, so you're not coming out of the liver capsule, you're puncturing the capsule and doing 3 actuations with a wet suction technique yielded significantly optimal specimens as compared to the 1 pass, 1 actuation technique. And then comes the question of Biloba. Can we get away with just one side? Do we have to pick right or the left? And again, we looked at our own data and experience here at Geisinger, along with our hepatology colleagues, and we had 38 patients with fatty liver disease. And we saw that the unilobar assessment significantly underestimated fibrosis by 21%, inflammation by 13%, and steatosis and balloon assessment by 8%. So in regards to NAFLD, especially where there could be regional variations, EUS-guided bilobar liver biopsy significantly improves the assessment of disease activity and fibrosis. And that goes again to the point of doing USLB, is it gives you that option to get a bilobar sampling. And in regards to the suction techniques, we did a pilot study, again, a randomized trial comparing wet to dry heparinized suction. And we assessed 120 biopsy specimens from 40 participants, comparing wet heparin technique, which is what you saw demonstrated earlier, with dry heparin compared to the dry needle biopsy. And the specimen adequacy was significantly better in the wet heparin suction technique, both in regards to the length of the longest piece, the aggregate specimen length, as well as the mean CPT count. So that has been our go-to technique for the suction applied to the 19 F&B needle. And there was a recent meta-analysis that was published that kind of re-emphasized all these points. There was 9 study arms from 437 patients that showed the pooled success rate for histological diagnosis was 94%. The adverse event rate was around 2%. And in a subgroup analysis, they saw that the FNA needle was, the adverse event rate was lower compared to the diagnostic yield was 98%. So the question that we come down to is, are we able to obtain histologically adequate specimen for liver biopsy via EUS-guided technique? And the answer is definitely yes, and I hope I've been able to convey that based on the clinical experience and the data that we've been able to publish and gain so far. And I'd like to just go over a couple of case examples to show how a case could easily encompass EUS liver biopsy. So we have a 65-year-old male with history of Barrett's esophagus, morbid obesity, and the whole metabolic syndrome, who's seen at our GI clinic and hepatology colleagues for elevated liver enzymes. And the blood work basically shows more of a parenchymal / slightly elevated alkaline phosphatase and mildly elevated bilirubin. The autoimmune and serological workup was negative, and the right upper quadrant ultrasound showed fatty liver and a bile duct of 4 millimeters, but no mass lesion. So the plan was that this patient required an endoscopy anyways for his Barrett surveillance. And given his liver enzymes, we did an endoscopic ultrasound to rule out a biliary pathology, which was negative. And then to assess the biochemical abnormalities, we were able to do an EUS-guided Biloba liver biopsy to assess the elevated LFTs and stage the liver disease. So obviously the endoscopy showed his persistent Barrett's esophagus, and we were able to obtain an EUS-guided liver biopsy specimen at the same time. And the EGD biopsy showed non-dysplastic Barrett's, and USLB showed cirrhotic nodular architecture consistent with moderate micro and macrovascular steatosis. So we were able to answer two questions at the same time, one to stage the fatty liver disease, and then two to get the diagnosis for the Barrett's. Another example is a patient who has undergone a cholecystectomy, is hospitalized for jaundice and right upper quadrant pain. A right upper quadrant ultrasound shows a borderline elevated bile duct at 8 millimeters. They couldn't assess the distal bile duct and thus cannot rule out a distal CBD obstruction. The patient has history of a recent sinus infection and completed an antibiotic course, and the liver tests are elevated with a bilirubin of 8. So we plan to do an EGD for the abdominal pain, an endoscopic ultrasound to rule out a distal CBD obstruction, given the findings on labs and abdominal ultrasound. And on the EUS, there was no CBD obstruction, and hence patient did not require an ERCP, but given the elevated liver enzymes, underwent an EUS-guided liver biopsy. That was able to be performed and showed intrinsic liver disease with acute hepatocellular injury consistent with drug-induced liver injury. So here we were able to assess for abdominal pain, rule out a biliary obstruction, and obtain an EUS liver biopsy parenchymal specimen, all in the same procedure. And one quick note on altered anatomy: even if patients have a Roux-en-Y gastric bypass who present for endoscopic evaluation, we're still able to do a unilobar left lobe access through the gastric pouch. And this patient came in for an endoscopy to rule out an anastomotic ulceration for the abdominal pain and for the evaluation of liver enzymes, and EUS-guided liver biopsy was able to obtain the histological specimen that showed advanced fibrosis without cirrhosis. So even in altered anatomy, this continues to be an option in patients who require an endoscopy anyways. So in conclusion, EUS-LB is becoming more commonly used technique for performing liver biopsy. It can be cost-saving when the patient needs an EGD or EUS, as well as a liver biopsy, and it can all be combined into a single procedure. It offers the benefit of sampling both the right and the left lobe of the liver. It is safe and yields tissue lengths comparable or better to percutaneous and transjugular techniques, and is best performed with a 19-gauge EUS FNB needle using a wet suction technique with 1 puncture, 3 actuation, and appropriate specimen handling. Thank you.
Thank you so much, Dr. Khara. That was a really great presentation, ton of great information in there. We do have a few questions that came through. So the first is, you spoke a lot about the heparinized wet suction technique. How would you recommend getting started to someone who's never used that technique before?
So it is actually very easily doable. The 19-gauge easy shot, as you know, is easily available in the endoscopy labs. And the heparinized wet suction, the heparin is already part of the endoscopy lab, so we use it as a heplock. So if you are an outpatient unit or an inpatient hospital-based unit, it's just something that you can order from the pharmacy. We stock it now in our endoscopy lab itself. and you would flush the needle, and then the suction at the end again is part of the needle kit. You would be able to use the water. But as I demonstrated, you would just do the needle prep ahead of time, and then puncture the liver, turn the suction on, do the 3 actuations, turn the suction off, and take the needle out.
Great. So another question here, and we're only going to answer a few here because I know we're running a little bit short on time. But someone submitted a question. So when a patient needs a portal pressure measurement and a liver biopsy at the same time, can it be done first in the same case? Which do you do first? How are the puncture sites different, and how is the case set up differently?
I mean, that's a great question. So there are 2 completely different needles. For an EUS-guided portal pressure measurement, it's a 25-gauge needle compared to an EUS liver biopsy, which is a 19-gauge FNB needle. So I would do the portal pressure measurement first. So you go transportal and transhepatic vein. So it's transgastric, and you would go through the liver parenchyma. So you're not puncturing the portal and hepatic veins directly. So you go through the stomach, through the liver, into a branch of the portal vein, and same thing through the stomach, through the liver, into a branch of the hepatic vein. And you would measure the portal pressures in each, and the difference is the gradient. Then you would do an EUS liver biopsy, again, with a completely different puncture site, because now you're not aiming at the vessel, you're trying to avoid the vessel. And for the USLB, you would go transgastric into the left liver parenchyma, and for the right lobe, you'd go transduodenal into the right liver parenchyma. Great feedback. So last question we're going to discuss here is, what is your relationship with your hepatology department, and how did you first build your endo-hepatology practice with them and actually build the relationship to have your hepatologist now referring cases to you for liver biopsy? So that's a great question. You know, it all comes out to collaboration. It has to be a group practice. You cannot just pick up a needle one day and start doing EUS liver biopsy. So this definitely started with discussion with our hepatology colleagues saying, yes, you're doing percutaneous and transjugular, but EUS-guided liver biopsy, we can do this. Give us a chance and let us see if it's feasible. And then we shared our data with the initial multi-center study. We also spoke with our IR colleagues, and this is where it's about the patient. You know, it's not about I want to do an EUS-LB or you want to do a transjugular. It's what's best for the patient. And I think the easy discussion is, if the patient is already coming to me for an endoscopy, would you want me to do an endoscopy, put them on sedation, do Barrett's biopsies, wake them up and send them to you for a liver biopsy? Or would you want me to just do it together at the same time? And the answer is clear. Of course, they're going to say yes. If they're already coming to you anyways and they need a liver biopsy, combine them together. So I think those are the easy discussions where you say, listen, if they need an IR-guided, CT-guided, or transjugular biopsy, fine, they can go to IR. But if they're already coming to me anyways, they're undergoing sedation, they're going to undergo an endoscopy procedure anyways, and they need a liver biopsy, I think it's very easy to set up that up. So I think it, again, comes to discussions of who is the ideal candidate. I think the case examples I just showed you, those are the easy pickings. And then talking to the hepatology colleagues along the same lines, that if you need portal pressures, I can do the PPG measurement and the liver biopsy all in the same session. And now I think it's even easier than before because we have a body of literature. We started off where we built the literature. Now there is all this data that it's more than adequate and comparable or better to the other techniques. So I think it's made the conversations a whole lot easier now.
Yes, you have definitely paved the way for many more to follow you. Okay, we have time for one last question here. Great question from the audience. So do you suggest endoscopists need a separate and specific credential for EUS-guided liver biopsy?
That's a great question. Again, comes back to talking with your admin, talking to the division directors. I don't think it requires a specific special credentialing. If you're currently performing EUS and FNA, this is along the same lines. You're using an FNB anyways to obtain cores from pancreatic tissue or any other tissue. This is along the same lines. It's just knowing the technique of how you're doing it. And I would addend the endoscopy protocol as an EUS liver biopsy because the complications are slightly different, right? I mean, if you puncture something, you would have a subcapsular bleeding. The patient may require to go to IR for hemostasis. So just to cover those points, I think it is prudent to make sure you addend your current protocols, but I don't think it requires a special credentialing. It just needs updating the endo lab policies for the same.
Great points. So I think that is where we're going to stop for this evening. For the other questions that are in the chat here, we did have an opportunity to answer some of them. So this is a recorded webinar and will be available to you shortly following the conclusion of the webinar this evening for you to watch back at your convenience. Just wanted to say thank you so much, Dr. Khara, for giving a great talk this evening. You've given everyone lots to think about moving forward. And thank you, everyone, for joining. I hope you have a great night.
Thank you.